Welcome to episode 12 of Unscripted Let's Talk. Today we are going to talk about the medications that are used in the treatment of depression and anxiety. And I have a special guest today. Her name is Rachelle Broveleit, and she is a physician assistant who works at Sanford Psychiatry with 17 years of experience, right, Rachelle?
17 years.
Yeah. And now, the way that it works as a PA in this field is how?
So as a physician assistant, we are trained in general medicine and we are tested in general medicine. So when we come out of our training, we are able to work in any field. And so it just so happened that when I left school and became certified, I found a job in psychiatry. And so then I've just specialized in psychiatry for the 17 years since in 2 different settings.
And you really like it.
I love it.
Yeah.
Love it.
Rachelle, just for everybody to know, Rachelle's like one of the smartest people I've ever met. And she's got a real funny look at her face as I say that, but I am not kidding. She's like really, really smart. So I'm really looking forward to this. So anyway, so when I am putting together my thoughts about what I want to hear you talk about, the first thing that comes to me is that when I present as a therapist to people that, hey, you maybe need to be on an antidepressant, maybe with some qualities of an anti-anxiety component to it, or maybe even an anti-anxiety medication, they get really scared. They interpret it sometimes as that they're weak or defective. And they have a lot of fear that they're going to lose themselves, they're going to become zombies, they're not going to have real feelings, they're going to be numb. And of course, they feel really embarrassed. What do you say to those people?
So I would say that's a big part of my practice, especially people who are new to psychiatry. So anyone coming in that's a new patient, a fairly large percentage of people have that fear, or all of those fears, some of those fears. And so my general approach is that I try to come into the situation as an information collector and then as an educator. So my job is to get every bit of information I can about what has happened in their life from a psychiatric perspective so far, and then to try to use that information to come up with the best idea of what I think is going on, and then to educate. So then if they have fears about starting something and how it's going to change them, then I will discuss with them that my goal as a provider is first of all not to be a paternal force. My goal is to be a partner with them, and so I work with them. I meet them where they are. So if they say I'm not ready to start medications yet, I have them come back in 2 or 3 months so that they can let that sit and think about it for a while and then go from there. I will try to discuss any fears that they do have about the medications. You brought up becoming a zombie or changing your personality. And I tell them 100% my goal is to have you be more of the person you want to be and not any altered being and not someone different than what your picture is. The biggest compliment I can get is when someone comes back and tells me, I'm like I want to be, or I'm who I was before, or I'm the person I always thought I could be. So I'm never really trying to quote drug, unquote anyone. I'm trying to just help accentuate the things that they like most about themselves.
I've had people say to me when the medication is right, that they have a feeling that they've come back from somewhere that they didn't even know they were.
Exactly.
and they're back.
Yes.
And they have like full access to who they are.
Right.
And they're so surprised by that. And one of the funnier things that people will say to me is that, maybe things are just better. Maybe that's what it is. And I'll say, well, no, I'll tell you what, just stay on the medication.
Right.
Because
it's very likely that it is, maybe things are better. I always acknowledge that.
Maybe.
But it very much is possible that the medications have just changed the perspective, right? Like that's what the goal is to help thinking to become more healthy instead of the pathology that we see with anxiety and depression that hurts people's lives. So.
And a lot of depression isn't what people think in terms of that you can't get out of bed, you're sobbing all the time, that sort of thing. Although, I mean, depression certainly can look like that.
For sure,
where
it
you
looks
can't
like that.
even get out of bed.
But that's an important thing that I bring up. I will ask them to start with describing, what does depression look like for you? And then they will give me, so usually the first couple things that are described are things that they have told me. They're kind of their own flavor of depression. And then I'll go through the whole list of the rest of the things, because I want to get the full picture, because lots of times people haven't necessarily connected symptoms to depression. Like, they don't even know that the fact that their concentration is poor is actually a symptom of depression. So then we beef up, well, like the evidence that depression is indeed what's going on by me going through the whole list. But I always try to take their version of it first, because some people will say, I get really lonely, or I get really, I isolate a lot. And that's the first thing that they notice. And that isolation is technically not even one of the criteria for major depressive disorder. So, there are certain things that a person knows they know, like they know what theirs looks like. And so I always ask that first.
Well, and one of the symptoms that I've seen that people really are surprised is a result of depression is when people are agitated and angry and irritated.
For sure.
And because everybody thinks, oh, it's that you're crying and sad. But when somebody is just really agitated, I mean, people just irritate them. I mean, that all can be depression.
For sure. There's definitely a group of people that's their main emotion that they have. They do technically have to have prolonged sadness or lack of enjoyment with it, technically.
Or just a feeling of no worth.
Yes.
Hopelessness.
But those first two have to be there. One of the two, either prolonged sadness or lack of enjoyment, must be there.
Yep.
So then it gets a little dicey if they don't have one of those things. If they don't endorse that, then it starts to, make the picture a little bit more complicated for me.
Yeah, a little bit, a little tougher.
A little
more interesting for you. So what are some of the different medications that are used for depression? I know there are different categories. There's different reasons you choose a certain one over another. And I know you can't begin to describe all that you know about this, but if you could do just some broad brush strokes.
Yes. So the main group that most people are familiar with are what are called SSRIs. That stands for selective serotonin reuptake inhibitor. And so that group of medications is your Prozac, Zoloft, Lexapro, Celexa, and Paxil. And that group is the reason it's so familiar is it gets used. It's super common. And so that would be kind of the one that everyone kind of knows about. The next group that maybe some people know about are what are called SNRIs. That's for serotonin, norepinephrine reuptake inhibitors. And so that is the group of Effexor, Cymbalta. There are actually a couple others that we don't use very often, but those are the most common. And those medications, unlike the first group, affect both serotonin and norepinephrine. So it's a nice option. Sometimes people need two neurotransmitters affected by the medication. The next one that's probably, and it is actually the most common med used for all of depression, is Wellbutrin. It's in a class by itself. It modulates norepinephrine and dopamine. So it's a great medication for depression alone. It becomes a little trickier to use with anxiety because it will actually create some anxiety at first. Okay. So it's a great medication for if someone just has depression, which there's a group of people that just have that. It's also a great medication when added to one of the other medications that has some serotonergic ability. So if we have serotonin already covered with a medication, I can then add Wellbutrin, and the combination is very nice. We get a very big umbrella of we're getting serotonin, norepinephrine, and dopamine all affected at that point in time.
So when is it that you decide to do that?
So if I have someone who, so generally speaking, I'll start out with the SSRI or an SNRI, and I like to get, I would love to get a 3-month exposure to a medication. Sometimes we can't because of tolerability, so we have to stop it and start something else. But if I get 3 months, I see that as a good trial. If I feel like the person's taking it most days and pretty regularly. Then if that doesn't seem to work, I might try the other class. So I might go from an SSRI to an SNRI. Try that. And if I've had a good trial in both of those classes, I'm very likely to add Wellbutrin at the next visit. So about 6 months down the road, I'm kind of looking at Wellbutrin as a possibility of adding, just because it definitely together, again, we get all of the neurotransmitters in play. And then outside of those three groups of meds, there are a couple others we use. In psychiatry, we use a medication called Remeron or mirtazapine quite a bit. It's a nice medication to use with folks who are having really low appetite or who are sleeping really poorly. You take it at bedtime, it helps you sleep. It also increases appetite. So it's not great with folks who are trying to lose weight. So that's a little bit of a challenge, but there's definitely a group of people. One of the things we say in psychiatry is it's perfect for older, elderly women who are feeling very sad and not sleeping very well and not eating very well. It's perfect for that group of people. There are a couple other medications called Vibrid and Trintellix, which are new medications. They are part of the way that they work is like an SSRI. So they're like an SSRI, but with an extra added bonus. They also work on serotonin in another way. So there are two mechanisms of action, both working on serotonin that are in these new medications. And the new medications are nice because theoretically, now I'm going to say that theoretically because there's studies supposedly showed this, but if we look at clinical experience, it's the jury's still out. They're fairly new. They're just in the last several years they've been out, but they theoretically have maybe lower stimulation of appetite and lower sexual side effects. So they're nice in that way because when I have folks who are really struggling with the other meds and tolerability because of that, then I have these other things. And then there are some meds to add. And so, but those are our basic antidepressants. Like that covers the most of, and then there are some other things that we will add.
Right.
Yeah.
So you're talking about serotonin, and I know that I, of course, know what serotonin is, but what's serotonin?
Right. So when I say neurotransmitter, these are the chemicals in the brain that go between nerve cells to turn things off and on to make things happen. And so, and when I say neurotransmitter, it doesn't mean that that chemical is limited to the brain, because serotonin is actually, it's found in spades in the brain, but it's also found very, very heavily throughout the gut. So one of the challenges with people when they start an SSRI is that they'll often get very nauseated. And then
maybe even a little lightheaded.
And lightheaded because it's affecting the brain.
Right.
Exactly. So yeah, those are the two main initial side effects that we see. And with the gut, also as time goes, sometimes there will be constipation and diarrhea on a little more chronic level with these meds because serotonin is still in the gut. And so whenever we're giving an SSRI, we're causing this kind of flood of serotonin both in the brain and in the GI tract.
And it takes a while for the body to adjust.
Yes.
But it's not the direct action of these medications, is it? It's what it prompts more production of serotonin, or is it actual serotonin?
So with an SSRI, what it's doing is it is actually, it goes to, so there are two different nerve cells involved in speaking in the brain, and it goes to the one nerve cell that has the ability to suck the serotonin back up. And that's how our body normally gets serotonin out of circulation, is it sucks it back into the nerve cell. And so what the SSRIs do is they shut that sucking back up. They shut it off. So what ends up happening is there's a lot more serotonin available because the vacuum that sucks it back up doesn't suck it back up. So you just end up with more serotonin out between. So it's actually our own serotonin that's going between the nerve cells, and it's still speaking to the receptors like it normally would. We're just making more of it available by stopping the vacuum.
Which is why it's so different than what was used ages ago, and probably before you were in practice, but not before I was in practice.
Certainly.
Where we only had central nervous system types of drugs.
Right.
And those are the ones that people think of. They think, well, I'll take this, it'll have some immediate effect. And that is not what these medications are.
These are working in a different way at the nerve cell level.
They're prompting more of
our natural serotonin to just be available.
Yes.
Yeah. So it's really our cells. It's really just like optimizing our own system. And the reason that there's a need for that is that people who have depression and anxiety are found often to have lower production of serotonin based on their genes. So the genes that we've identified related to depression and anxiety find that people are just low producers of serotonin. And so the person is often always sitting on the edge. And this is from birth. So I educate people about this a lot. This is from the moment you are conceived. This is happening. You are at a disadvantage based on your production of serotonin. And so that is...
So life looks very different to these people
from the very beginning.
And so they're wiring their brain in some somewhat depressive ways or anxious ways from the beginning.
I always describe it as like there's this threshold above which you have to stay to not be depressed, and you're just much closer to that threshold. So then so that's why in psychiatry we'll call it a two-hit hypothesis. There's the genetic component that happens at conception, but then there's the next hit that happens, which is life. And so if life is tooling along and some big thing happens, we know that stress and stress hormones cause us to produce less of these neurotransmitters. So you're already hanging just on the balance of it, and then people will say, I went to college, I missed my family, I
had
was dating someone, and
someone I really loved died. Any number of things.
And then that was when I had my first depressed episode, which then, and then the problem is that we also know that the more depressed episodes that you have, the more likely you are to have them. That pathway gets going. So, after one depressed episode, and I'm going to say, when I say depressed episode, I'm talking about 2 weeks straight of either sadness or lack of enjoyment. So if people are having a few days here and there, that is not a full depressed episode. But if you've had 2 weeks straight of either sadness or lack of enjoyment, and you've had one of those, you are 50 to 60% likely to have another episode in the next 3 years. If you have two of those episodes, you are 70 to 80% likely to have an episode in the next 3 years. And if you have three of those, you are 80 to 90% likely to have another episode. So at 3 episodes, we tell people lifelong medication if you've had major depressive episodes. 3 or more.
Which, see, you're jumping way beyond my questions, Rachelle, because I was about to say all of that.
Zooming ahead.
How long can, that's fine. That's beautiful. So if it's the first episode, truly the first episode, what I've seen is that sometimes, like maybe just a really traumatic divorce, and you need to go on medication because you feel emotionally like you've been kicked by a horse. Those people can go on medication for a year, maybe 2. They can work through it, release it, and they can be off the medication.
For sure.
But if you've had multiple times like this,
we recommend after 3 lifelong medication, because
that makes so much
you're
sense.
so likely to go back into a depressed episode. And the other thing that we know about that is that these medications are neuroprotective. So before we had medications, one of the big causes of dementia eventually for people was that they'd had so much depression, because depression is neurotoxic. It actually causes cells to die. And so, we also have a bunch of evidence that shows that every depressed episode you have, it's harder to get back to baseline. People function less well the more depressed episodes they've had. So if we can, after an episode or 2, if we can keep you on medications, we are much more likely to keep your brain healthy for the longevity of it than we are if we just keep having depressed episodes.
Yeah. So a lot of people will be listening to this, and I've had people say this to me too. Well, they're addictive. You have to be on them the rest of your life. That means they're addictive. They're not addictive.
They are not. And so addictive in the way of medication really is dependent on a couple different things. It's dependent on having tolerance to the drug. So needing to have an increasing amount of the drug over time. And that a lot of times people can relate that to alcohol. Alcohol is one of those things that has tolerance to it. So you drink, and then, you have to drink another drink to get the same effect, and then another drink, and pretty soon you're at 6 or 7 drinks where it would have been 2 before. So that's tolerance. The other thing you have to have to be addictive is withdrawal. So withdrawal means that you stop the substance and you have symptoms because you're withdrawing from it. And so that is part of the reason, the withdrawal effect is part of the reason why people think there's an addictive tendency to these meds. But the withdrawal is not, it's not a dangerous withdrawal with these meds. It's just an uncomfortable withdrawal.
Right.
And so that's kind of the drawing line there. And so yeah, these medications are not addictive when they've shown people to be on the same dose of these medications for years, 10, 12, 15, 20 years. and they're having the same effect at 20 years as they did at the beginning. So there's no tolerance to it. And again, the withdrawal is a different type of withdrawal. It's not a dangerous, potentially life-threatening withdrawal. It's a discomfort. The body does miss it, but it's not shutting down because of missing it. So
that's a huge difference. As an addiction counselor, one of the things that I say to people, I've never known an addict who's willing to wait 3 weeks to have the impact of what they're taking. And it takes, 3 to 6 weeks
right. It
for
takes
a therapeutic
2 weeks,
level.
Yeah, 2 weeks for any effect. So that's very important. That's probably the most important
And I don't
part.
know any addicts that'll wait 2 weeks.
2 weeks for any effect. And then 6 to 8 weeks before the curve straightens out, before
you
full effect.
really know that they're
Exactly.
at a
So I don't
therapeutic
see
level.
anyone back. That's another thing is I often will not see anyone back until 6 to 8 weeks because I can't tell anything before that period of time. The only time I will see someone sooner is if I can sense that the person is needing more support and comfort. And then I will see them back sooner, and then I see them again. So it's not that I won't, it's just that for the understanding of what the med is doing before 6 weeks is really not helpful. It just is confusing.
And I'm sure what you say to them is that if they have some unusual reaction, to call your office immediately.
For sure.
There is a very rare unusual reaction.
Yes.
And of course, everybody seems to have heard some scary story about these rare unusual reactions. Can you talk a little bit about that?
Right. I mean, I think we see a wide variety of things, and a lot of them are the nausea that you were talking about before, the dizziness. Those are I describe those before the person even leaves my office because they are likely to happen, but they are transient, so they are going to go away. I have a rare person who we can't get nausea to go away. Like it happens rarely, and usually they have GI stuff before. So that does happen, but most of the time that goes away within a short period. There are some people who have increased anxiety with these medications at first. And if you do look at the curve for anxious symptoms, it does go up a little bit before it goes down. So I will usually tell my anxious folks, be careful of that the first week. If you feel more anxiety, give us a call. There are some things we can do with medications, but that is something that happens. So there are groups of people who will have almost a panic attack from taking these medications because that burst of serotonin at first is enough to throw things off in the brain, and the brain goes into that short-circuited panic kind of mode. So that is something that definitely happens. And then I hear a wide variety of other things that people will describe, and it's very hard sometimes to tell if this is one of those effects that happens to 0.5% of the population, or if it's something else that's going on for that person, if it's a coincidental kind of thing. Headaches are a big thing people talk about. The tough part with headaches is they're on every list for every medication, literally, and they're also something that comes because of all sorts of other things. So, our sleeping and our eating and other meds we're taking and all sorts of things will affect headaches. So not to say I'm blowing off headaches, but I definitely want to see them happening every day after you take your medication on a regular basis. If they're happening here and there, it's probably not the med.
So do you take the medications in the morning, at night, once a day, more than once a day? How does that work?
Generally, these are once a day. They've worked to get them once a day. Wellbutrin and Effexor, which are pretty common medications, they initially were 2 to 3 times a day, and that goes more poorly, right? People are
That's tougher to remember to
very
do.
hard. Yes, compliance goes way down. So what they did is they did extended releases of both of them. So they now have a once a day dose of Effexor and of Wellbutrin. Everything else was already once a day. I recommend that these be taken in the morning to start off with. The reason for that is that they all can play with sleep architecture. So that's just a side effect of these meds. People will sometimes say, I wake up more. And as long as the person is waking up but easily going back to sleep, I don't do too much about that. But sometimes that's a problem. And but I try to do it in the morning to keep it from affecting bedtime.
All of the different meds?
All of these that we're talking about, I try to do in the morning to start off with. But there is a group of people that feels pretty, it's not really sedated, so I don't want to use that term because it's not like I'm going to fall asleep. It's just like a little bit like the wind is taken out of their sails, like a little bit slow and kind of almost too calm, and that's probably what it is. It's just like slowing you down so much that it's your normal kind of anxious, feeling is kind of, it's taken away. And so you're very peaceful. And then, so some of those people, I will move it to bedtime. And they still do okay with sleep for the most part. And then they don't complain about how they're feeling in the morning. So some
Right.
people will move it to that.
I remember a woman who was taking Lexapro, this was years ago, and she did feel better, but it did just put her to sleep if she took it in the morning. And I said to her, well, take it at night.
Let's move it to bed.
Just move it to bedtime.
Yes.
And that took care of it all. Because
And
by morning,
yes.
it had been in her system
Exactly.
long enough. And she then over time made the adjustment.
Exactly. Because within 3 months or so, most of the time, these things have kind of resolved themselves
Yeah.
anyway. Your body gets used to it and does. But yeah, I tell people, and a good point with that is I want every person I ever see, and I think most providers do, if you are having a problem like that, let us know.
Okay.
Like, don't suffer with that. We have the ability to do lots of emailing, messaging, which is hugely helpful. But we also still take phone calls all day, every day. I have a nurse who that's what she does all day long is fields phone calls from people. So you don't have to sit and suffer until the 2-month appointment. Is
Right.
what I would say about that. Let your provider know, because for me, it's going to be a minute of reading the message, responding to the message. And for you, it could change your next 6 weeks.
Right.
Yes.
Good.
Yes.
So I'm going to have you come back, Rachelle, and we're going to talk some more about depression, but we're going to add anxiety to the discussion. But I want to kind of wrap up for right now, and thank you so much.
No problem.
And as I told you, isn't she smart? She's so smart. So, to my listeners, remember to live your life with purpose, passion, and intention. Until next time.